Hello everyone, welcome to our third lecture of autonomic pharmacology. In this video, we are going to discuss about cholinergic or cholinomimetic drugs. So at first, a quick recap from previous video. In previous video, we have discussed how acetylcholine is synthesized, stored and released in the synaptic cleft. After releasing of acetylcholine in the synaptic cleft, it will bind with acetylcholine receptor on the postganglionic nerve fiber, and stimulation of the acetylcholine receptor leads to stimulation of cholinergic or parasympathetic nervous system. So acetylcholine, after doing its job, it gets metabolized, and the enzyme which helps in the metabolism of acetylcholine is called acetylcholine esterase enzyme. So if we want to stimulate the cholinergic nervous system, we have two options. Either we can directly stimulate this acetylcholine receptor, or either we can inhibit the acetylcholine esterase enzyme, which will leads to less metabolism of acetylcholine and increased concentration of acetylcholine in the synaptic cleft. Increased concentration of acetylcholine will stimulate increased number of acetylcholine receptor, so there will be stimulation of cholinergic nervous system. So the drug which directly stimulate the acetylcholine receptor are called directly acting cholinomimetic drug, and another group of drugs which inhibits the metabolism of acetylcholine esterase are called indirectly acting. So at first we will discuss about drugs which directly acts on the acetylcholine receptor. The first drug is acetylcholine itself. If you can collect acetylcholine from human or other animal and use it as a drug, yes, of course you can, but there will be no clinical utility because it will have more adverse effect. Why? Because acetylcholine will non-selectively stimulate the nicotinic and muscarinic receptor. That will lead to various systemic adverse effect, which is unwanted. So we will not use acetylcholine clinically. Then our next drug is pilocarpine. The third drug is bethanicol. The number 4 drug is methacholine. And our last drug here is carbachol. So at first we will discuss about pilocarpine. Pilocarpine acts on pupil. From previous video we know that pupil contains M3 receptor. Stimulation of M3 receptor causes stimulation of parasympathetic nervous system, and we know that parasympathetic nervous system only inhibits the heart, and all other organ or viscera are stimulated by stimulation of parasympathetic nervous system. So stimulation of parasympathetic nervous system in pupil will lead to constriction of pupil, which is known as meiosis. The meiotic utility will help in angle closure glaucoma. Now, how meiosis helps in angle closure glaucoma we will discuss in details, and the mechanism of it when we will discuss about anti-glaucoma drug. Then our next drug is bethanicol. Bethanicol works on bladder, and we know that bladder contains M3 receptor. So stimulation of M3 receptor of bladder will lead to stimulation of parasympathetic nervous system on bladder, and stimulation of bladder will lead to increasing contraction. So contraction of bladder, this utility can be used in atonic bladder. Atonic bladder means the tone of urinary bladder is totally lost, means that there is no contraction of the bladder and the bladder is paralyzed. This condition arises after abdominal surgery. When the surgical instrument or the hands of the surgeon touches the urinary bladder, the bladder gets paralyzed. And after the surgery, we have to stimulate the bladder by using methanical. The same mechanism is also used in paralytic ileus. Ileum contains M3 receptor which causes peristalsis and helps in paralytic ileus after operation. We can also use it in newborn babies whom have aganglionic megacolon. Aganglionic megacolon is a genetic abnormality where the ganglion which stimulate the colon is not produced. So there is no contraction of the colon and fecal material accumulate in the colon and the colon becomes larger, mega in size. That's why it is called aganglionic megacolon. By using bithanicol, we can get rid of aganglionic megacolon. Next drug is methacholine, which stimulates myocardium of heart. And we know that myocardium contains M2 receptor from our previous video. So stimulation of parasympathetic nervous system will cause bradycardia, and this utility can be used in tachycardia and arrhythmia. And our last drug here is carbachol, which stimulate both muscarinic and nicotinic receptor. It has got the maximum power of stimulating nicotinic receptor. We need to remember one use of carbachol, that is the same reason like pilocarpine M3 stimulation. When carbachol is topically used on eye, it causes stimulation of pupillary M3 receptor, which will lead to miosis, and miosis can help in angle closure glaucoma. Again, the mechanism we will discuss in antiglucomal drugs. A trick from me: how we'll remember the drug and the use of those drugs. Pilocarpine starts with P and it works on pupil, which also starts with P. Bithanicol starts with B and the bladder also starts with B. So bithanicol works on bladder M3 receptor. Methacholine starts with M and myocardium starts with M. So methacholine works on myocardial M2 receptor. Nowadays only pilocarpine is clinically used. The bithanicol, methacholine and carbachol are not now clinically used because they contain a large group of adverse effect. Pilocarpine doesn't causes much adverse effect because it is used topically on pupil. So now we are going to discuss about our second group of drug, which is indirectly acting cholinergic drug. We have previously discussed indirectly acting cholinergic drug acts by inhibiting the acetylcholine esterase enzyme. There are mainly two types of indirectly acting drug. They may be reversible and they may be irreversible. We can easily understand from their name that reversible drug binds with acetylcholine esterase in such a manner that it can again be separated from acetylcholine esterase enzyme and acetylcholine esterase enzyme is reactivated. But irreversible indirectly acting cholinergic drugs permanently inhibits the acetylcholine esterase enzyme. As a result, there is permanent increase in acetylcholine in the synaptic cleft and there is permanent stimulation of cholinergic receptor that leads to permanent stimulation of parasympathetic nervous system. So we do not want to stimulate our parasympathetic nervous system for lifetime. So irreversible drugs are mainly toxic. So now we will discuss in detail about reversible indirectly acting cholinergic drugs. We have four drugs here. Physostigmine. The second drug is neostigmine. Third drug is pyridostigmine, and fourth drug is edrophonium. So the four drugs are physostigmine, neostigmine, pyridostigmine, and edrophonium. So at first we will discuss about physostigmine. Physostigmine is a lipid soluble drug. We just need to remember the lipid soluble information from physostigmine. And we have discussed in general pharmacology that lipid soluble drug can easily cross the lipid bilayer of cell membrane. So it can easily enter and leave the cell. So as it lipid soluble, it can cross the gastrointestinal tract. For this utility, we can use it orally. As it is lipid soluble, it can also cross the cornea and binds with pupillary M3 receptor and stimulate it. And we know that if parasympathetic nervous system is stimulated in pupil, the pupil is contracted and that leads to meiosis. And previously we have discussed that meiosis will help in relief of glaucoma. So physostigmine drop can be used in angle closure or open angle glaucoma. The exact mechanism we will discuss in anti-glaucoma drug. As it is lipid soluble, it can also cross the blood-brain barrier and enters into the brain, so it has CNS effects. Those CNS effects are mainly adverse effect, but this utility can be used in atropine poisoning. We will discuss in details about atropine in anticholinergic drugs. A quick recap of atropine here. Atropine is also a lipid soluble drug. It crosses the blood-brain barrier and enters into the brain. Atropine is selective muscarinic M1, M2, M3 receptor blocker. So as a result, it blocks the M1, M2 and M3 receptor in the brain and spinal cord and inhibits the parasympathetic outflow. So if we use physostigmine in atropine poisoning, physostigmine will inhibit the acetylcholinesterase enzyme and there will be increase in acetylcholine in the synaptic cleft. As a result, there will be more acetylcholine that will stimulate the parasympathetic receptor and reverse the adverse effects of atropine poisoning. In this group, the next three drugs, neostigmine, pyridostigmine and edrophonium, are water soluble. We discussed in general pharmacology that water soluble drug cannot cross the GIT, so we cannot give it orally. It must be given IV or IM in parenteral route. As it is water soluble, it cannot also cross the cornea and cannot be used in glaucoma. This drug also doesn't cross the blood-brain barrier. So there is no CNS adverse effects. So these drugs are mainly used for peripheral parasympathetic stimulation. So now we will discuss about use of these three drugs. We can categorize the use of these drugs in two categories. First category is only nicotinic use. This means this will only stimulate N and N-M receptor. So how can we use it as only nicotinic receptor stimulator? We can add atropine with it. We have previously discussed that atropine blocks M1, M2 and M3 receptor. So when the M receptor are blocked by atropine, these three drugs will only work on nicotinic receptors. So what are the use? We can use it in myasthenia gravis. We will discuss in details about myasthenia gravis after this discussion. We can also use it in cobra bite. In forensic medicine, we have discussed that cobra venom is neurotoxic and it blocks nicotinic and and NM receptors. So these three drugs, neostigmine, pyridostigmine, and atropinium, can be used with atropine in cobra bite. It can also be used as reversal of muscle relaxant. Actually, what muscle relaxant does? Muscle relaxant blocks or overstimulate the NM receptor. So by giving an stimulator, neostigmine, pyridostigmine, or atropinium, we can reverse the effect of muscle relaxant drugs. These drugs are regularly used after anesthesia or surgery to reverse the effect of anesthetic drugs, which causes muscle relaxation during the surgery. And now, if we do not use atropine with it, what will happen? So, if we do not use atropine, there will be no muscarinic receptor blockade. So, these three drugs will stimulate both nicotinic and muscarinic receptor. So, here we can use this utility. We can use this in post operative, that will reverse the muscle relaxation that occur during surgery. It is also used in post operative urine retention. We have discussed earlier why urine retention occur after surgery. By stimulating M3 receptor, the urine retention is reversed. Now we will discuss in detail about myasthenia gravis. At first, what is myasthenia gravis? Myasthenia gravis is an autoimmune disease. Body immunity produces antibody against an M receptor. As a result, the NM receptor is blocked. So, acetylcholine cannot work on muscle. So, there is no muscle stimulation, and that leads to muscle weakness. So, what is myasthenia gravis? Myasthenia gravis is an autoimmune disease in which our body forms antibody against NM receptor or nicotinic receptor which are located on the muscle. As a result, NM receptor are blocked and acetylcholine which worked on NM receptor cannot work now. As a result, there is no muscle stimulation or no movement of muscle, and this will clinically present as muscle weakness. We need to discuss in short about another disease which also leads to muscle weakness and closely related to myasthenia gravis, that is cholinergic crisis. In cholinergic crisis, what happens? There is too much concentration of acetylcholine in the synaptic ganglion. As a result, there is very much stimulation of an M receptor, and that leads to over contraction of the muscle. When the problem starts, initially the muscle are hyperactive, but day by day the muscle become non-responsive, and this clinically present as muscle weakness. So, the clinical feature of myasthenia gravis and cholinergic crisis are same. How to differentiate between them? There is a test called tensilon test. This is very important for Viva. Which drug is used for tensilon test? That is edrophonium. We have discussed about edrophonium, which is water soluble drug before. At the beginning of the test, edrophonium is given IV. Why it is given IV? We previously discussed it is water soluble drug. Edrophonium is a very short acting drug. It works less than 10 minutes in the body. So when the drug is given IV, Hydrophonia inhibits the acetylcholine esterase enzyme, so there is less metabolism of acetylcholine in the synaptic cleft and increase in concentration of acetylcholine. So increased amount of acetylcholine will bind to an M receptor and stimulate the NM receptor, and temporarily the muscle will contract and muscle weakness will be gone. Quick recap: hydrophonia binds with acetylcholine esterase enzyme, which leads to inhibition of acetylcholine esterase enzyme. So there is less metabolism of acetylcholine in the synaptic cleft and increased concentration of acetylcholine in the synaptic cleft, and that leads to stimulation of an M receptor, and that leads to temporary contraction of the muscle, and for short time muscle weakness is lost. But if the muscle weakness is due to cholinergic crisis, the increased concentration of acetylcholine due to use of hydrophonia will worsen the condition. Hydrophonia is given IV. It binds and inhibits acetylcholine esterase enzyme. As a result, there is increased concentration of acetylcholine in the synaptic cleft. So increase in stimulation of an M receptor, and muscle is stimulated. So the muscle weakness is lost temporarily. But if the muscle weakness is due to cholinergic crisis, then giving hydrophonium IV will increase in concentration of acetylcholine. In cholinergic crisis, there is already increased concentration of acetylcholine in the synaptic cleft, so that will worsen the condition, and the muscle weakness will be more if there is cholinergic crisis. So this is tensilon test, which is required for differentiation between myasthenia gravis and cholinergic crisis. Now, what about the treatment of myasthenia gravis? For the treatment of myasthenia gravis, neostigmine or pyridostigmine is given. We have previously discussed there is 3 reversible indirectly acting cholinergic drugs. Those were neostigmine, pyridostigmine and hydrophonia. So we used hydrophonia for tensilon test. Why we used hydrophonia? Because it was very short acting. But we will use neostigmine or pyridostigmine for the treatment because they are long acting. To avoid the muscarinic adverse effect, we can use atropine with it. So that's all about myasthenia gravis. Now the last group of drug are irreversibly acting drug. These drugs are toxic as they permanently inhibit the acetylcholine esterase enzyme. They are mainly organophosphorus compound and carbamate. There are many organophosphorus compounds. They are like parathion, malathion. These two drugs are used mainly as insecticide and they are very toxic for human. In our next video, we are going to discuss about OPC poisoning and management, which is very important for Viva and written. Thank you everyone for being with me.